So now, let's take a little bit of a review of the immune system and the lymph system. So we're going to start by looking briefly at structures and some functionality of the lymph structures. Then we're going to switch and talk about the specific immune response, non and specific. So lymphatic system first. You know, your lymphatic system has lymphatic organs whose job is filtration and surveillance. And those are specifically the spleen, the thymus, the tonsils, and the Peyer's patches. We also have lymph nodes, which are small nodule-like structures, therefore filtration and surveillance. There are cells that are immune system cells housed within. So those are specialized structures, and those are going to be considered lymph nodes. And then we have to have some way of collecting lymph and moving it through nodes and organs, and then eventually returning to the blood supply, and those are lymphatic vessels. So let's take a look at each of them. Let's start with lymph vessels, and in fact we're going to focus on capillaries. Lymphatic capillaries are different, obviously, than blood capillaries. So here's an example of a lymphatic capillary. You can see first they're blind end, meaning they're closed off on one side. You know, the goal of lymphatic capillaries is to collect lymph and move it one way. So it makes sense that they would be blind. That's going to help them be one way. They're also incredibly permeable because you can see these little flap-like mini valves. So once fluid goes in, it can't get out, and it also is forced to go one way. You have lymphatic capillaries everywhere, and as you can see in this diagram here, they are intertwined with blood capillaries in most places. Remember, the job is to collect leftover interstitial fluid, basically. So that, again, makes sense that we're going to find them with blood capillaries. The only place you don't find them is teeth, bone, bone marrow, and central nervous system. In teeth and bone, there just isn't interstitial space, so there just isn't interstitial fluid. Bone marrow, you know, that's got like sinusoids, so bone marrow is all about producing cells and getting them out. So we just don't have a lot of lymphatic interstitial fluid collecting. And central nervous system uses a completely different transport method anyway. Flow of lymph through vessels and nodes and organs is very, very slow. And the reason is because it's an incredibly low pressure system. In many, many ways, lymph vessels are similar to veins. So that means we're going to have to rely on our skeletal muscle pump and our respiratory pumps to provide the force to move fluid through lymph vessels. Some lymph vessels, the very big ones, also have a teeny bit of smooth muscle in them, so they have a limited ability to contract. So again, we're going to collect lymph in a lymph capillary. Lymph capillaries, as you can see on this diagram, will converge to form lymph vessels. Lymph vessels converge to form even bigger vessels that some books call lymphatic trunks. And large lymphatic vessels or trunks converge to form two ducts. The right lymphatic duct brings lymph and returns it to the blood supply at the right subclavian vein. And you can see it drains the right upper quadrant of the body, like not the whole head, but the right upper quadrant of the body. All other lymph eventually finds its way into the thoracic duct, which returns that lymph to the blood supply on the left subclavian vein. So again, collected in a lymphatic capillary, converge to form lymphatic vessels that will have to rely on respiratory and skeletal muscle pump action and limited constriction to move lymph fluid through. Vessels converge to form larger structures that books will call trunks. Those converge to form even bigger vessels that return the lymph to the blood supply on a subclavian vein. A vessel that returns lymph to the blood supply is a duct, and we have two, right? Lymphatic or thoracic. The last structure you see here is a convergence of large vessels, the convergence of trunks, and that structure in the abdomen here, that's the cisterna chyli. So it's a convergence point. Now along the way, if we're going to gather up all this fluid, it makes sense to filter it. And site of filtration and surveillance is the lymph nodes. Filtration is to remove things that shouldn't belong, and surveillance is keeping watch and triggering the immune system if we need it. The function of that again is the lymph nodes. So one more time from the top, lymph gets collected in a lymphatic capillary, which converge to form vessels. As the vessels move through the body toward the ducts, that lymph is carried through these lymph nodes for filtration and surveillance. And when we're all done filtering it, we can dump it into the duct. Lymph nodes are found kind of in three major collections. And the three major collections are the cervical in the neck, axillary in the armpit, and inguinal down here toward the groin. If we take a cross-section through a lymph node and look at it, we'll find that as far as immune system cells are concerned, we'll find macrophage, T lymphocytes, and B lymphocytes. Structurally, you can see each lymph node may have many afferent vessels, but very few efferent vessels. That helps to ensure that the lymph more or less backs up and moves very, very slowly. Remember, a lymph node is kind of our last chance to find a pathogen. If we miss the pathogen, its next stop is a duct, and after that, it's the systemic blood supply. So we're going to do everything we can in a lymph node to catch things that don't belong. All lymph nodes have a kind of fibrous connective tissue outer structure called a capsule, and the capsule invaginates in structures called trabecula, which divide up the node into small compartments called lobules. In lecture I said, think of this as the apartment complex, and these are the walls that separate an individual apartment. And then a lobule is an individual apartment. Inside we find reticular fibers, because this is a reticular connective tissue, and we find reticular cells. Reticular cells are responsible for creating and maintaining the fiber and the ground substance that's in this node. Your book mentions something called stroma. We don't really go into it, but stroma is the ground substance for a lymph node. Okay? Okay, so let's take a look now at the regions in the cells. So same concept, if you divide through a lymph node, you'll find that it has some regions to it. The outer region is the cortex, this inner region is the medulla, and then when the vessels begin to leave the node, that region's called the sinus. And you can see over here that the cell populations change as you're in the different regions. The cortex has more lymphocytes, so B's, T's. The medulla has lymphocytes and plasma B cells. And then the sinuses have more reticular fibers and more macrophage. So I'm not going to answer this question because I want you to think about it. It is true, if you get an infection, the lymph nodes closest to the site of the infection swell. Realize swelling is inflammation. And we've talked about inflammation before, and you learned about inflammation in AMP1 and the fact that that triggers tissue repair. So why is it that lymph nodes swell when an infection is occurring? Use your recently gained knowledge, like a slide ago, about the cells that you would find there and how they might react if they see a pathogen. So even though you're responsible for just understanding that there's cervical, axillary, and inguinal nodes, I do want to point out to you that the location of an individual node in those regions is known, and every one of them has a name, and the names aren't that obnoxious, like preauricular means before the ear, posterior auricular, behind the ear, occipital, because it's on the occipital bone, submaxillary, under maxilla. Okay? So when a healthcare provider is palpating someone's neck, they're feeling these individual nodes to see if they're swollen, because that is an indication of an infection. These are some swollen axillary nodes, and it's hard to see it, but there's swollen inguinal nodes here as well. Well, in addition to nodes for surveillance and filtration, we have other lymphoid organs as well. The difference with these is there's no afferent vessels to them. So there's no lymphatic vessels coming immediately in and out. These tend to be associated with a tract, like respiratory tract, digestive tract, oral cavity, wherever our body's in contact with an environment. We also have a specific organ in here, the thymus, and then we have a specific one that's spleen. So they're reticular tissue for the most part. We find lymphocytes in them, but they're not nodes. They're not part of that lymph transport system. If we look at the spleen, we'd find that our spleen has that capsule. It's got trabeculae. It even almost looks like it has lobes. Its tissue is differentiated into red pulp and white pulp. Red pulp is going to be associated with red blood cells and white pulp associated with white blood cells. The deal with the spleen is it is where red blood cells go to die. Okay? Once upon a time, we talked about what happens to red blood cells when they get worn out and when their membranes become fragile and lyse. So this is one of those organs that deals with these dead and dying red blood cells. So the spleen would remove red blood cells and even platelets from the blood supply. And then as the red blood cells are broken down, the spleen has the ability to store and later release breakdown products of the red blood cells. So iron, for example. So your spleen can store iron and release it when you need it. The white pulp is more resident macrophage, and its function is to filter blood as it comes through. The spleen is one of those interesting organs where if it's inflamed or necrotic or damaged, it can be removed, and the patient has their liver and their bone marrow take over the functionality that the spleen would do. So that's spleen. Red blood cells go there to die. It can store and later release the breakdown products of red blood cells. So example, iron. So you'd have iron on, hemosiderin in this organ. It's also where a lot of macrophage would filter blood from pathogens or debris. Thymus. Your thymus sits up here by your trachea. When you were young, it was huge. Now as an adult, it's atrophied and become much, much smaller. The thymus is where your T lymphocytes become immunocompetent, and that's why they're named T cells. So when you were young, you needed to build up this massive supply of immunocompetent T cells, and now that you're older, you just need to maintain them. Immunocompetence is a process by which cells become mature. Tonsils. Tonsils are in the nasal cavity up here and in your oral cavity. They are kind of a first line of defense. They're immune system tissue on a mucosa in contact with the environment. We have 3 sets of them. The pharyngeals are way up here in your nose cavity. Your palatines are back here at the back of your soft palate on the sides of the back of your oral cavity. I'll show you a picture. And then you have a lingual set that's at the back of the tongue. These are normal palatine, see their location? Tonsils. This is the fauces, which is the archway at the back of the mouth. Here's the uvula. It's part of your soft palate that hangs down. And in people who have these tonsils, these nodules here aren't bad. They're not tumors. Those are nice, healthy, beautiful tonsils. Sometimes bad stuff happens, though. They become infected. They become inflamed. This is obviously a set that's inflamed and has had an pyogenic infection. There's pus nodules forming. This obviously needs to be treated. Sometimes people get little white things on their tonsils. It can be a fungus. Sometimes it's just nothing at all. But this is a bit excessive. So if this were combined with other signs and symptoms, it would be an indication of tonsillitis. And in fact, I Google imaged tonsillitis to find this picture. Right? But that's not enough. We're going to toss in a few others. So some other lymphoid organs are tied to mucous membranes. And so those are called mucosa-associated lymphoid tissues. They're lymph nodules, so they're not really a grown-up organ on their own, but they're lymphoid nodules and follicles and pieces that you find in a mucous membrane. So Peyer's patches are these that we find in the small intestine, and you saw earlier on the diagram where Peyer's patches are, so associated with small intestine. Appendix has a lot of lymph nodules in it. That would be at the end of our cecum. And we even have some lymphoid follicles in our bronchi as well. So you should be able to understand why these two tracts. Why digestive and respiratory? Now, when we started talking about the immune system, which we are now, I did a lot of building up in class. And I said one of the things about it is it's kind of difficult to understand because it's not an organ system you can dissect out. It also tends to be tied to the lymphatic system because it just makes sense. If you're going to collect interstitial fluid and call it lymph and return it to the blood supply, it makes sense to filter it along the way. So the immune system is very much tied to the lymphatic. Our immune system has two categories. We have nonspecific or innate. Your textbook might call it innate. I-N-N-A-T-E. Your innate is your first line of defense. It's in you. It's already there. You were born with it and it's working at all times. It's the same behavior every single time. The downside is it doesn't have any memory, and I'll tell you what memory is in a second. And of course, they have to mow the lawn when I'm trying to record a lecture. The other part of our immune system is your specific or adaptive immune response. This thing doesn't happen first. It's your second line of defense. It's different every single time you do it because it's customized to specific antigens. But the beauty of it is it maintains memory. So here's some of the things of the non-specific, and I'm just going to touch on them briefly because I focused on it more in lecture. Again, the non-specific is designed to keep things out, or if something gets in, to prevent it from spreading. So one of the things we look at is the fact that the surface of our body has barriers. We're going to talk about the different kinds of barriers that we have. That's going to try to prevent something from getting in. If something gets in, we're going to try to get rid of it and prevent it from spreading. We're going to do phagocytosis. We have eosinophils, neutrophils, and macrophages that can do that. We can stimulate inflammation. That brings more cells to the site of a damage or infection. We secrete cell products, which can block virus replication or allow cells to communicate with each other. We can trigger fever, which by raising the temperature makes reactions happen faster. And we can also use our friendly neighborhood natural killer cells, which have the ability to phagocytize cancer-infected cells and virus-infected body cells. Right, so surface membranes here. Your skin is I don't have a picture of your skin here, but your skin is a great barrier because it's stratified squamous epithelia that's relatively waterproof. So everywhere you have skin, it's going to be very hard for pathogens to enter. It's just a physical wall. Where you don't have skin, you have a mucous membrane, and that's going to force us to rely on multiple mechanisms. In your respiratory tract, we have this beautiful pseudostratified ciliated columnar epithelia, right? Goblet cells in there make mucus, particles get trapped in the mucus, cilia moves the mucus along. So in our respiratory tract, this tissue acts as a filter. You could catch some nasty little bug in the mucus, and then you're going to move it off the epithelial tissue and get rid of it. Your eyes don't have this, but in your eyes you tear, and there's lysozymes and things in your tears that help flush bacteria and items off the surface of your eye. The vagina has acidic secretions. I did say don't use that as a birth control method in class. But it has acidic secretions that help prevent pathogenic microbes from colonizing it. In class, we talked a lot more about some of the things we do in our different mucous membranes. Digestive tract, the stomach is very acidic. So make sure you if you missed that lecture, that you do go in and read the textbook, because it's the surface membrane talk we had is more than just these two pictures. All right, then we have general phagocytosis. This is a macrophage attempting to phagocytize some bacterial cells here. That's to eliminate the pathogen from our system. And remember, neutrophils can do it, macrophage can do it, and eosinophils can do it, albeit weakly. This is a natural killer cell trying to phagocytize a cancer cell. That's an exciting picture to me. Natural killer cells are nonspecific because they don't go after specific pathogens. They go after our cells that are infected or cancerous. And then I said cell products. We have a couple of kinds of cell products. One group of them are called complement. Complement proteins, when activated, do a couple of things. One of the things they stimulate opsonization. Opsonization means that these complement proteins would bind to the membrane or wall of a pathogen, and that makes it easier for a macrophage to phagocytize it. The other thing that different complement proteins can do is they'll come together when they're activated and they pop a hole in the wall of a bacterial cell, and that would kill it. So lysis and opsonization belong to complements. Inflammation, making it red, hot, puffy, and sore. The goal of inflammation, though, is to bring more immune system cells to the site of an infection. So when it happens in acute form like this, it's a good thing. It's going to trigger an immune response and tissue repair. One of the other immune system products we have for nonspecific is interferon. Interferon is produced by cells, and it helps them block the replication process for viruses. The only downside is we don't make a lot of it. And lastly, I mentioned fever. Fever is about raising the body temperature slightly. It's controlled by hypothalamus, so that molecules and chemical reactions happen faster. It's our body's attempt to make our immune system just move a little bit faster. The downside with fever is when it gets too high. So I'm not going to go through this, but what I want you to do is I want you to stop or pause the slide. I want you to start up here with what would happen if you cut yourself or injured your tissues, and how that's going to result in movement of white blood cells and changing capillary permeability, vasodilation, and how you're going to get inflammation and ultimately healing. So now let's put nonspecific together with specific. Let's look at the events of an immune response. An immune response is going to follow the sequence. Cells have to have the ability to recognize what's foreign from what's not foreign. So we have to start with recognition. Then those cells can phagocytize. Once they phagocytize the pathogen, they will lyse it. Okay? And this is macrophage. In lecture, I talked about what neutrophils do, how they behave very differently. Neutrophils are strictly nonspecific. Macrophage are part of the bridge between, innate and adaptive. If it's a macrophage, once it's done lysing the pathogen, it'll choose protein, usually based structures, molecules, pieces of the pathogen, and it's going to determine that that's going to be a great antigen, and it does something called presenting the antigen. Presenting the antigen is the moment where everything switches from just trying to prevent this thing from spreading to attacking it as a very specific entity. At that point, we're going to activate two processes. One is the cell-mediated response, and the other is the antibody-mediated response. The goal of all these steps is to neutralize the pathogen, to get the pathogen out of your body and to prevent it from causing signs and symptoms. In lecture, we went over all the cells, so you should have an understanding of each cell type and what its function is as part of the story. If you missed that, you want to stop and review. All right, I've already mentioned a word called immunocompetence. In order for us to do this, we need to have a cell-mediated response. We need cells that are immunocompetent. We need cells that are mature. When T cells and B cells are first formed, they're considered immature. They haven't learned what kind of antigens they can respond against yet. They have to learn how to do that. And it's all based on receptors on the cell membrane. They have to change the receptors on their cell membranes. B cells stay in the bone marrow and become immunocompetent in the bone marrow. But T cells, once formed, are going to go to the thymus and become immunocompetent after the thymus. And also recall from our lymphatic system talk that a lot of our T cells are going to wander through the body and go into tissues and just be everywhere. But a lot of our B cells are going to be focused in lymphatic system organs and in special places. Alright, so let's look briefly at how we can do recognition. We're going to use a gene system called the major histocompatibility complex. There are 3 levels of genes, basically. The first level of gene are class 1, and they are used by all cells in the body to make receptors. So these are considered MHC class 1 receptors. One function for these is a self sign. Every cell in your body has the same class 1 receptor on it. That lets every one of my 100 trillion cells knows that the cell next to it belongs because the class 1 receptor matches. The other way our body cells can use class 1 receptors is regular body cells, certain ones, have the ability to present antigen. If they do that, that's how a natural killer cell knows who to kill. So it's a little white flag sign that they put up and say, hey, I'm sorry, I'm infected. And then they get killed. So those are both those mechanisms, the giving themselves up for the cause, presenting an antigen, or the ability to know what belongs are class 1 receptors. Class 2 receptors are read by leukocytes, produced by leukocytes. They're going to allow, say, a macrophage to present an antigen. They're also for communicating with each other. The last set of genes are really used to make cell products. So these are our white blood cells again, producing complement, interferon, interleukins, antibodies, all the molecules they produce as part of the immune response. The instructions for that are in MH3 class 3 genes. So, how does a macrophage know what belongs versus what doesn't belong? Let's pretend a macrophage is cruising through my body right now, or it's hanging out in a lymph node and it's checking out the lymph as it moves by. Everything that macrophage would come into contact with, it would essentially chemically check to see if there's a class 1 receptor. If a class 1 receptor is there and it matches, the macrophage interprets that as belonging. It says, that class 1 receptor matches mine, therefore that's part of my body, I'm going to leave that alone. But if there's no class 1 receptor, or if the class 1 receptors don't match, the macrophage says, you know what? That's not me, and attacks it. So that's it. That's what recognition comes down to. Do class 1 receptors match? Right. So if a macrophage sees that there's no class 1 receptor, or let's say the class 1 receptor didn't match, it would phagocytize it, lyse it, and then choose pieces of this pathogen that it feels would cause a good reaction that everybody else could recognize. And there are rules to that. They tend to be large molecules, they tend to be protein-based, blah, blah. But for the sake of our discussion, we're going to trust the macrophage's ability to choose an antigen, a piece of the bigger pathogen. This macrophage is going to take that piece, stick it to a class 2 receptor, and put the entire thing on its surface. So this is a presented antigen. It's a piece of antigen on a class 2 receptor dangling out in space. Once we get that, this is going to be the signal to the rest of the immune system that the body's under attack, and that specific thing is what to go after and kill. Once you get a presented antigen, our next cell in line can show up, the one that looks like a star here. This next cell is a helper T cell. Once a presented antigen occurs, a helper T cell will stick to this complex. That's like knocking on the door of the macrophage. So once the helper T cell binds to the site, the macrophage knows, my T cell's here. And it needs to communicate with the T cell. So it's going to secrete a molecule called interleukin 1. That interleukin goes to the T cell and activates it. So this T cell didn't know what to do. All it did is it saw a presented antigen and it stuck to it. Now all of a sudden the macrophage sends it a message in the form of interleukin. And that molecule tells the helper T cell it's time to wake up, it's time to get to work, and it's time to go after this antigen. An activated helper T cell will now pop off, separate itself from the macrophage, and go out into the body to trigger certain cells and processes. This story doesn't end. Yet another inactivated helper T cell will bind, become activated. So once antigen is presented, macrophage can affect many, many, many T cells. So what's the deal? An activated helper T cell is an incredibly busy cell. Every time you activate one, it's going to trigger several other events. One category of events is the antibody-mediated response, which we're about to talk about. And then when we're done looking at that, we'll look at the other series of events, which is the cell-mediated response. You can't get anything that's about to follow, which is a pretty good conversation. You can't get any of these events without an activated helper T cell. So again, let's focus on the antibody-mediated response. An activated helper T cell, once it pops off that macrophage, it goes and affects B cells. It will stimulate B cell clonal expansion. That will result in a rapid increase in the number of B cells. It's kind of like mitosis, but it's fast, exact mitosis, basically. So all of a sudden, we're going to get this huge rise in the number of B cells, lots and lots of B cells in the matter of hours. Once we have all these B cells, the activated helper T will stimulate B cell differentiation. So all these new B cells are going to differentiate in their function. Some of them will become plasma B cells, which go on to make a customized antibody. And some of them are going to become memory B cells. They'll maintain, I'm going to say, a copy. They'll mutate their own DNA so that they know what the antigen looks like. So we pretend, say, 5 years from now, you get infected with this antigen again. The memory B cells will trigger an immune response so that you get rid of the pathogen before it causes signs or symptoms. So memory B cells are kind of handy to have. They're going to make sure we don't get the same flu virus every single year. So now we're going to shift, since this is the antibody-mediated response, we're going to look at those antibodies that plasma B cells make. So again, we activated a helper T, it activated B cell clonal expansion. And then it did B cell differentiation. So now we ended up with tons of B cells and some memory cells. B cells are going to make antibodies. An antibody is a protein that has a piece of it that is custom made against the antigen. Like that protein will only bind to that specific antigen. So we're going to take a bacteria, essentially, or a virus, and we're going to cover it, absolutely cover it, in custom made antibodies. Once you get plasma B cells, they make these custom antibodies incredibly fast. Each plasma B cell can secrete about 2,000 antibody molecules per second for 4 or 5 days. So you could see that the titer, or the amount of antibody against this antigen once we get to this stage, is going to increase dramatically. The only issue is it's going to take us a few days to get to the stage. In the meantime, you don't feel very good. And remember, B cells are going to be made as well, memory B, and what they will do is on a second response stimulate antibody release. So instead of having to go all the stuff we've done so far and build up the number of B cells and then get antibody, you would stimulate antibody production immediately. So you don't get sick the second time around because the antibodies clear the pathogen out before it can form signs or symptoms. So let's take a second and just talk about antibodies. We didn't get a chance to do this in lecture. Antibodies, there's 5 different major kinds, but at the end of the day, they have conserved structures, meaning they have structures that they share. And so we can look at this antibody as being kind of sort of Y-shaped. And the different antibodies are just going to put these Ys together in different ways. Most of the actual Y is actually conserved. It's exactly the same between the different antibody types. What changes, so it says constant there, what changes is the little tips. So even though a plasma B cell is going to custom make an antibody, it doesn't start from scratch. All it does is custom make the edges. Okay. It's these edges that are going to bind to the antigen. You could also see that an antibody has a part that's big, that's called the heavy chain, and it's got a little side part that's lighter, that's called the light chain. So it's this antigen binding site that gets manipulated. Some books call that an epitope. So if you see that word in a book or something, you'll know that they're referring to the antigen binding site. So here's how we put these different things together to create different antibodies. Here's my heavy chain, and here's my two light chains. So there's my Y-shaped structure. Some Y-shaped structures are used to just kind of leave it in that form. So it's a certain kind of heavy chain, and that's called IgG, immunoglobulin G. So this is one kind of antibody. There's a different kind of antibody called immunoglobulin A, and you can see it has a different kind of heavy chain. So here's IgA. Don't memorize the heavy chain, just know that the chain is different. If we do it again and create yet a different kind of heavy chain, we get immunoglobulin D. You got it, do it again. We get immunoglobulin E. You can see the structure is pretty much conserved. It's just different heavy chains. And some of these antibodies exist in a state where there's multiple ones stuck together. This is immunoglobulin M. I've got 5 separate antibodies stuck together. So let's look at these 5 immunoglobulins and what they actually do for us. IgA is found in mucosa, so mucous membranes. It's also found in saliva, tears, and breast milk. So it's transmammary, crosses the mammary glands. It prevents colonization of bacteria. So the fact that immunoglobulin A is sitting on the mucosa helps prevent bad bacteria from growing on our mucosa. And so you can see the benefit of having it in saliva. It's going to prevent bacteria from growing in your mouth. These are bad bacteria to a degree. You can see why it's beneficial to be in tears, because that's going to help prevent bad bacteria from growing on the surface of the eye. You could also see why it's good to have in breast milk, because that's going to help the baby who receives that breast milk not have bacteria colonize them. Immunoglobulin D is basically stuck to B cells and is used as a receptor for B cells. It's the receptor that helps B cells activate basophils and mast cells. Immunoglobulin E is involved in the allergic response. It binds to allergens and it triggers histamine release. It also has a limited effect against parasitic worms. Immunoglobulin G, or gamma globulin, is the most common. Over 80%, 80 to 85% of the general and traditional B cell antibody binds to a bad thing is IgG. Thankfully, it's transplacental, so it actually crosses the placenta and helps protect the baby. And then we have that last weird one, IgM. If you have one IgM by itself, it's a B cell receptor. But if you stick them together in groups of 5, like the pentamer, then it acts as a very early system, general immunity, attached to the bad guy antibody. But there's not that much of it, and it's only around in the very beginning of an immune response in this manner. The big guy you're going to rely on to help you get better is IgG. So you actually do need to understand these 5 different antibodies. So what do antibodies do? At the end of the day, antibodies neutralize pathogen. But when an antigen and an antibody meet each other and agglutinate in the body, that triggers a lot of events. So one of the things is this: we're just going to neutralize it. Bacteria and let's stick with bacteria first. Bacteria cause problems because they produce toxins that kill our red or white blood cells or make us very sick. They secrete enzymes that dissolve our tissues. They have structures that allow them to attach to mucosa. So by covering it in these little custom-made Y-shaped antibodies, we disable all those mechanisms. That bacteria can't secrete its toxins or its enzymes, and it can't stick to the mucosa. That means it can't infect us anymore or cause signs or symptoms. Viruses cause trouble in our bodies because they stick to our cells. Literally, they bind to cell surface receptors, and they get in the cells, and then they force the cells to make more virus particles. So by covering a virus in custom-made antibody, it can no longer stick to a cell receptor, and it can't get in a cell, and then therefore its life cycle can't be finished. I shouldn't have called it life cycle. Its replication cycle cannot be finished. So we're going to neutralize the virus. Agglutination also helps us deal with cell-bound antigens. We talked about agglutination in the world of red blood cells. But if you think about it in terms of the red blood cells, if I'm blood type A, I have antibodies against B. If you give me antigen B, I'm going to destroy those cells. But that's fine because that's not me. We also have the ability to do precipitation. When you get agglutination, just like on that blood plate, that's something big. That comes out of solution. That's also something other cells can recognize. So we have even other leukocytes we never mentioned that recognize all this precipitated antigen-antibody complex, and they'll actually phagocytize that. When antigen and antibody meet up, that fixes complement, so that's going to make sure we get more opsonization and more bacterial lysis. When antibodies and antigens meet up with each other, that is also a trigger to increase phagocytosis. And then we talked about what complement can do. So in order for us to really get better, we have to get to the point where we make a bunch of antibody, because that's what's going to stop the free bacteria and the free viruses from getting in, and that's what's going to stop the infection. But that's only part of the story. So while antibodies are all about neutralizing pathogen directly, the whole rest of the immune response, the cell-mediated response, is about cleaning up the damage that's been caused, clearing out the body cells that have already been affected, and activating other cells. So whereas our activated helper T cells stimulated that whole antibody-mediated response, it also stimulates this cell-mediated response. And I've cut it down, believe it or not. So an activated helper T will activate cytotoxic T cells. They'll go out, cruise through the body, find infected body cells, and destroy them. Activated helper Ts also activate natural killers. Remember, they're the ones that are anti-cancer or virus-infected cells. They'll go in and kill those. And activated helper T cells stimulate macrophage and mast cells and B cells and everybody to secrete their cell products. So we're going to get even more inflammation, even more complement, even more interferon, even more interleukins. So you can see the importance of an activated helper T cell. It's the guy that helps you get better. It's the guy that tells everybody else what to do. So same concept, just different flow chart. We have a cell like a macrophage present an antigen, helper T cell binds to it, becomes activated. It stimulates production of B cells, which make antibody, which help us neutralize the pathogen. It stimulates other cells, I know it's a grainy picture, stimulates other cells to produce their cytokines or their leukocynes, same thing. It stimulates natural killer cells and cytotoxic T cells. All of this is designed to neutralize the pathogen and destroy the rest of the pathogen. So this is our last slide. If you get exposed to an antigen, an actual bug, a virus or a bacterium, and you go through this whole process from beginning to end, that's called active immunity. Takes about 2 weeks to finish this whole thing to where you finally feel better and you finally have cleared the last of the pathogen. The beauty of active immunity, though, is its long-term protection because you have memory cells. If you get exposed to the same antigen, You're not going to develop signs and symptoms because you're going to make tons of antibody on first exposure, and the antibody is going to neutralize all the pathogen before it can make you sick again. That's how it works most of the time. If, let's say, this is a baby and the baby receives antibody across the placenta or through the breast milk, that's considered passive immunity. It's immediate protection because it's antibody. The downside is antibodies only last 7 to 10 days and then they break down and the body clears them out. So it's short-term protection, there's no memory, but at least it's immediate. We humans looked at this and we manipulated this. So we have passive immunity vaccinations, which are gamma globulin. So if someone, say, works for the Peace Corps or Doctors Without Borders or in the military, and they have to leave tonight and go someplace tomorrow that has a high rate of a certain disease, we can give that person antibody against that disease so that when they get off the plane or the boat, they've got immediate protection. We also have created active immunity vaccines, vaccinations where we give the antigen. The pathogen has been mutated, so it's not going to cause signs or symptoms. Like the flu shot doesn't cause the flu virus. In lecture, I talked about why people might actually get sick. It's other reasons. But the beauty of getting antigen is you develop long-term protection. Some vaccines, the antigen isn't that strong, and it's related to the fact that they had a mutated, so it didn't give you polio. But sometimes the antigen isn't really strong enough to get enough memory cells, and those are the ones where you have to go back for boosters. Okay, so if you've ever had like a tetanus you need a booster like every so many years. And that's just because they can't make the vaccine be safe, but strong enough to produce all the memory cells you need. So hopefully this helps you put the immune system and its events and the lymphatic system into perspective.